Learning about the changes of function according to age, that is at puberty, before adolescence and above, and then in middle age and old age. What happens in puberty? What happens next in the middle age? And what happens in the old age? One should be clearly, one should clearly understand what the changes are happening in prostate. Alright, prostate develops by third month. Prostate develops by third month. By some endodermal part, solid endodermal parts from the urethral sinus, that is the pelvic part of urethral sinus. From there, some solid parts comes out. By fourth month, this part forms canalization. Sorry, there is canalization, and thereby formation of ducts and follicles. After the formation of ducts and follicles, you can call it a prostate. Then you can call it a prostate. And the stromal tissue around the prostate is formed by the splenic layer of the primary viscera. Splenic layer of primary viscera. So the endodermal solid parts, they are canalization, and the endodermal mesodermal stroma, this forms the prostate. Right? Now Prostate is situated at the neck of the bladder, and this angulation is produced by the detrusor muscles of the urinary bladder, and below it is continued as the urethra, pre-prostatic and prostatic urethra, where there is the Bell's muscle. Bell's muscle means when the mesonephric duct of both sides, makes an trumpeting, both the ducts make trumpeting and communicates with one part with the other, and this part is the pre-prostatic urethra in the bladder trigon, and the trigonal muscle is the Bell's muscle or the internal sphincter for the urethra. Is the trigonal muscle for the internal sphincter of the urethra. Now, here you can see that this prostatic part of the urethra is continued downwards, passing through the deep pouch, that is the perineal membrane, as the lower leg, and it is connecting with the spongy part of urethra below. And on either side of this, there is bulbourethral glands, or paraurethral glands. The muscle you see on either side of the spongy urethra is the membrane, sphincter urethrae membranacea, and another muscle that you can see is the transversus perineal profundus, that is in the muscle of the deep pouch. And below it is continued into the superficial pouch. Below it is continued to the superficial pouch. Now we divide the prostate in some lobes for surgical and basically for not for anatomical understanding but for surgical understanding. There is medial lobe to inferior to lateral lobe and anterior and posterior lobe. And in case of surgical consideration, we call anterior and posterior lobe, median and lateral lobe, median and two inferolateral lobes. Median and two inferolateral lobes. The structure of prostate is fibromuscular. The structure of prostate is fibromuscular. The fibrous tissue makes consequently three septa in between the glandular tissue. The glandular tissue makes three compartments. One with the main, the mucus gland portion within the central part, then the intermediate septum, then the peripheral septum. These three septum divides the prostate into the zones, where in the posterior part there is a posteriorly we see a septum that communicates with the inner circle of the prostate, and ventrally skeletal muscle that covers the prostate makes an isthmus, that is crisscross between the muscles of two sides. So the innermost circle, intermediate circle, and the peripheral circle. And the peripheral circle, the muscle forms the crisscross muscle fiber, the skeletal muscle fiber, and gives rise to the formation of the isthmus. Now we divide the prostate in another way for surgical need. That is the central part, intermediate part, and the peripheral part. That is, central part is 70 to 75%. Intermediate part is around 20%, and transitional part is 5%. For benign prostatic hypertrophy, we look for the central part, whereas in carcinoma of prostate, we look for the peripheral part. There are biomarkers that needs to be evaluated. That is the prostate-specific antigen and prostate-specific protein. Prostate-specific PSA, it is the product of the prostatic endothelial tissue, and it remains. Its ranges is 4 to 10 nanogram per ml. This gives rise to the prostate PSA. Alright, this gives rise to the PSA. And there is another biomarker that is called PAP. Now, when we analyze the semen, we see that there is a portion of the prostatic secretion within it, and there are acid phosphatase, proteolysin, prostaglandin, and the glucose within the semen, which this part comes from the prostate. This part comes from the prostate. In puberty, up to puberty, there is lack of prostatic secretion as well as amount of sperm that comes to the seminal vesicle. In the subsequent stages, there is increase in the secretion of the prostatic secretion, forming the semen. And in the old age, all the glandular and alveolar character, collapse, and there is formation of a starch-laden hole. Once there is collapse of the glandular and ductular, ductular and glandular part, when it is collapsed, it gives rise a starch-laden hole of tissue, which is known as corpora amyloacea, which can be visualized through FNAC. It can be seen in FNAC, by needle aspirated cytometry. Now, in case of benign prostatic hypertrophy, adenocarcinoma of prostate, we need to see the prostatic tissue, and we do number one study of biomarkers, and number two is the rectal examination, and number three is the transurethral dissection of prostate. Prepare for transurethral dissection of prostate. This is TURP. What you need to know when you pass the dissectoscope upward through the urethra, you need to find the area where you need to stop. That is the folliculus seminalis or the verumontanum. When you find the elevation of the folliculus seminalis, that is the verumontanum, you need to stop there and start moving the rotating blade. That will give rise to the transurethral dissection of prostate. But nowadays, Though it is done, transurethral prostate is done, but it is not that much, uh, it is not that much good, because once there is transurethral dissection of prostate, the patient bleeds profusely in the postoperative period. The patient bleeds profusely in the postoperative period, and it is tough to control this bleeding following transurethral dissection of prostate. Got my point? Though it is the most easiest way to approach to the prostate, especially for malignancy. And once it is known that the patient doesn't have malignancy, then you stop doing cutting of the prostate and treat the patient with 5-alpha reductase inhibitor. That is, the testosterone causes proliferation of the epithelium that gives rise to the pus. So the testosterone is converted to dihydro 5-alpha reductase. Then testosterone is converted to DHEA. Okay. DHEA, and then we inhibit this 5-alpha reductase, and if the patient has, that is in the old day, the patient might have enough estrogen and there is enough androgen receptor, and we can use androgen to treat such a patient. In old age, the patient might have enough estrogen. So enough estrogen gives rise to enough endothelial receptor, and you can give 5-alpha reductase inhibitor, and there will be less proliferation of the aldosterone receptor, and the further proliferation of the mitogenic cells will be suppressed. Further proliferation of mitogenic cells will be suppressed due to suppression of the cells having androgenic receptor. If the androgenic receptors are suppressed, then 5-alpha reductase inhibitor will not work for such kind of patients. Got my point? If there is enough estrogen, there will be enough steroid binding receptors, and you need to stop or inhibit this steroid binding receptor. Until and unless you bind the receptor, steroid inhibitors will not work. This is the mode of approach to either prostatic hypertrophy or prostatic cancer, that is adenocarcinoma. Now, handling a case with urinary symptoms, that is retention of urine, anuria, hematuria, pain, all this is to be separated. And to understand which pathology is working, producing the clinical symptoms you are presented with. Alright. If it is anuria, whether there is renal failure or not. If it is anuria, where there is bladder tumor or not. If there is hematuria, whether there is bladder papilloma or bladder stone is there. Like this. You have to separate out and differentially diagnose which factor is acting, in this case or in this patient. Alright. I will discuss afterwards.